I would like to thank Microport for the invitation and the co-chairs of this symposium. And also I would like to thank Dr. DeBoer for this nice introduction, making me blushing a little bit. I'm going to talk about muscle activation, and it's an electromyography study. And this is part of a larger study that we're looking at the kinematic kinetics, and here I'm just presenting the EMG results. Oops, okay, wrong direction. Disclaimer, this is, we received research support from Microport, and the other one is my other conflict. Several studies have shown that TK improve pain and function, especially for a patient who has osteoarthritis and severe osteoarthritis. But if we look at the biomechanical discrepancy remain quite large if we compare to healthy controlled people, then we're just wondering what will be the level of muscle activation that will improve functional performance and also will improve stability of the joint. Then if we're looking at the various type of implants on the market, and I think we have seen this morning a series of that, the question is mainly, the implant design can affect muscle activation. Do we have something that will improve? And looking at the muscle activity for greater or smaller ADL, I mean activity of daily living, walking on level or going downstairs or ramp or sit to stand are something that patient always wondering, especially doing downstairs or down a ramp, patient complaint. Then we have investigated muscle activities of the affected leg, and also the other leg, but the purpose is mainly to compare medial pivot and posterior stabilized during a stair descent task. It's a prospective study, a control case study of 28 patients, 14 in each group. We had the medial pivot and posterior stabilized. We pretty much male and female equal. Age is about the same, not significant. BMI pretty close, not significant. And the patient were coming to visit the lab pre-surgery, a month prior, and post-surgery 12 months, and all the surgery has been done by the same surgeon, and the surgery approach was the subvastus approach. And they're coming in the gate lab, like I mentioned prior, and post-surgery. We set up the skin markers for the kinematics. We set up the EMG sensor, 10 EMG sensor on the quadricep, hamstring, and also a gastrocnemius. All patients went through a MVIC, maximum voluntary isometric contraction. We used that to normalize our EMG. And we asked the patient to do a stair descent using 3 trials at their self-selected pace. Then we had the onset. What is the onset? It's when the muscle is turning on in relation to foot strike. Total time activation during the gait cycle. This is another parameters that we measure. We're looking at the maximum normalized EMG signal during the whole cycle of the stair descent. And we're looking at the total muscle activity normalized to MVC, then for the whole cycle again. And all has been compared and processed in using ANOVA. The result, looking at the onset of the quadricep. Now I want to guide you a little bit on these figures. When you're looking at the left-hand side, we're looking what is significant is the onset. On the right-hand side of the figures is the length of when the muscle or the time the muscle was on. And when we're looking at this figure, the MP had earlier onset on the vastus medialis and lateralis, and the MP had a longer total time for all quadricep muscle than we have on this figure. If we're looking at the hamstring, no significant difference for the hamstring. That means both groups, they had about the same onset. And if we're looking at the gastrocnemius, it was the same. And the onset, it was not a factor for the other muscles. Looking at the peak, where they get the maximum, then now we have only one muscle who's significant is the rectus femoris, where the PS is larger, but in the situation that we have here, the VL and VM were not significant, but we see that the VM were a little bit less for the PS group. For the hamstring, only the semitendinosus where we have significant difference, and PS was larger for this muscle. Looking at the gastrocnemius, in this situation, the gastrocnemius PS at the larger peak of EMG on the lateral and medial head of the gastrocnemius. And if we look at the co-contraction, nothing was significant, but we can see that the quadricep to hamstring co-contraction, the PS had much more co-contraction. Then, in terms of discussion, what we can make sense of this data, that we know by the kinematics that the PS group has a tendency to have what we call a quadricep avoidance pattern during gait, and it was about the same thing for doing downstairs. Then the strategy, what they use a strategy to avoid shear displacement on the operating knee. Then they try to minimize the loading, but that's not what they do. They do more co-contraction. This could be why we can explain that. It could be year of adaptation, trying to protect their joint, but we see that surgery with the PS is not establishing a better pattern of gait. Then later, later VM and VL muscle onset and short activation in the PS group duration is indicative of the quadricep avoidance pattern. And more co-contraction is also another factor that showed that patient has more co-contraction. MP group show more efficient neuromuscular function. MP group activate VM and VL muscle earlier and longer duration without increasing the peak or total activation, also with less co-contraction. PS patients require more muscle activation over a shorter period of time and complete the same movement or the same task that they had to produce. Then in conclusion, MP implant group result in more efficient neuromuscular function. MP patient better able to load the operating knee and did not show any quadricep avoidance gait pattern. Thank you.